I'm pleased to introduce Nicole O'Brien as our next speaker. She is an occupational therapist working at Parkwood Hospital in London, where she currently works on the stroke inpatient rehab unit and the comprehensive outpatient rehab program. She is a volunteer co-chair for the Southwestern Ontario Stroke Network's OT network and was also part of the 2024 Southwestern Ontario Stroke Network's Return to Work Resources Working Group. Nicole will speak about enhancing stroke recovery, integrating, applying return to work resources in clinical practice. Welcome, Nicole.
Thanks, Jen. So thank you so much for having me today. I really hope my presentation is useful and I can provide some tools that you can apply to your clinical practice. So as Jen said, my presentation is around enhancing stroke recovery, integrating and applying return to work resources in clinical practice. So this presentation is completed in collaboration with the Southwestern Ontario Stroke Network, also known as SWOSN. And I also wanted to thank Libby Forges and Shannon Hansberger, who helped with the development of this presentation. So this is just a disclaimer slide. I don't need to go through that. So learning objectives. So I'm hoping today you'll leave with a greater understanding of the significance of addressing return to work following a stroke. Throughout the presentation, I'm going to explore the development and evolution of the SWOSN return to work resources. And then we're going to examine a case study demonstrating the application of return to work resources in clinical settings. So the first part of my presentation is going to discuss the importance of returning to work following a stroke and also exploring the literature about return to work post-stroke. So when we look at the Canadian Stroke Best Practice Guideline recommendations, they have a whole section related to return to work. Within that section, it recommends assessment of vocational interests and assessment for potential to return to vocations. And when we say vocations, it can be things like work, school, or volunteer. It encourages a gradual return to vocations. It recommends referrals and/or vocational counseling for return to work. And lastly, it recommends the review of financial concerns, sustainability, and benefits. So the Stroke Best Practice Guidelines are telling us that addressing return to work following a stroke is important, and this is also found in the literature. So the literature has found that 1 in 4 individuals who have experienced a stroke are under the age of 65. So this tells us that there is a large portion of people who have experienced a stroke that are likely still working. Research has also found that return to work rates following a stroke are as low as 7.3%. And one systematic review found that 41% of subjects returned to work following a stroke between 0 and 6 months, and 53% at 1 year. So even though we know that many people who have had a stroke are within the working class, research is telling us that there are still many people who are not returning to work following a stroke. And return to work, working in general, is a really important social role. And not being able to return to work following a stroke may have a negative impact on someone's quality of life. It can affect emotional, physical, and social health status. It can affect their financial situation and also negatively impact their self-efficacy as well. So when we're looking at return to work post-stroke, there are additional considerations that are important. The first is that there are unique rehabilitation needs of young stroke survivors. So people who are younger and have experienced a stroke are more likely to experience complete or functional recovery, stay longer in rehabilitation, have dependents such as children, be engaged in full or part-time employment prior to the stroke. And also often there's a strong motivation from a societal viewpoint to re-engage and return to work due to a longer lifespan. So the literature suggests that getting people back to work following a stroke is really important, but one study found that 68% of young stroke survivors complained of significant work dysfunction, despite having a good clinical outcome at 7 months post-discharge. And another study found that 20% of individuals who had returned to work at 1 year post-stroke had dropped out of working life by the 5-year follow-up. So even though we know return to work is important post-stroke, in the literature, it's telling us that success rates of returning to work after a stroke aren't great. And it's important to note that when we're discussing the success of return to work, actually returning to work is only the first step to reemployment. There's also other things to consider, important pieces to consider, such as can the person retain their job, and also how well are they performing at their job. There's also many different barriers to return to work. This slide just outlines a few. I'm sure there's many more, but just to give some examples, one barrier can be the impact of stroke and residual effects. So this can be things such as the stroke severity, what their physical ability is, if they have cognitive deficits and aphasia. Another barrier can be the approach used in rehabilitation. So maybe return to work was not discussed with the client, or it wasn't focused on rehabilitation, even though it was important to that person. And also, as we know, the return to work process is a complex system to navigate. There's many different parties involved, which can be really challenging for the client to navigate, but also challenging for therapists to navigate as well. Another barrier is employer and work environment characteristics. So sometimes there's a lack of understanding by the employer about stroke, and this can lead to an inflexibility or failure to accommodate someone. And then there's also external barriers, such as architectural barriers. People may not have transportation to get back to work. There may be few jobs in certain areas. And also there can be stereotypes against people who are disabled. Just as important to look at the barriers, it's also important to look at the enablers for return to work. Some of these can be individuals' motivation or their attitudes about return to work. People's return to work experiences are often impacted by the attitudes of the employer and also their employees. And support in returning to work, just some few different things that we can do is provide specific skill development, support for a gradual return, longer follow-up support in the workplace, around 5 years, for example, and also having a liaison between the rehab professionals and employers. And also looking at the principles of return to work rehabilitation. One of the pieces is providing training, so occupation-specific preparation and training, providing education within the target workplace, having participation by the person who has experienced a stroke in all management aspects of their rehabilitation, and also advocacy, so having ongoing workplace advocacy from a stroke educator. So given that return to work is an important piece of stroke recovery, we need to consider and look at what tools and resources are available to support someone who has experienced a stroke in returning to work. And that leads into the next part of my presentation, where I will discuss the development of the SWOSN Return to Work Toolkit. So just to go over briefly the history and evolution of the toolkit. So the process of developing a return to work toolkit began in 2008. During that time, data was analyzed across Ontario to examine access to rehabilitation and provide an in-depth analysis of care transitions in stroke. So through community engagement forums, SWOSN identified that return to work was a priority area of focus. At that point, a working group was created. Within the working group, it included therapists, a person with lived stroke experience, an owner of a private vocational rehabilitation company, and also SWOSN staff. And together they created a self-assessment guide to return to work. And these are one of the tools that I'll go through with you in a few minutes. So like I said, the initial development occurred in 2008. From 2008 to 2018, the toolkit was started to be implemented and used, and it was continued to be reviewed. From 2019 to 2023, continued use of the toolkit. There was promotion of the resource, and also other stroke networks started using it and adopting it. And then in 2024, the resource was revamped. There was a working group established. We collected feedback both from clinicians and also people who have experienced a stroke. And then we incorporated that feedback to improve the overall use of the toolkit. So what is the toolkit? So there's 5 different components of the Return to Work toolkit, and I'm going to go through each component in more detail. For each of these resources that I'm going through, they can be found as a PDF on the SWOSN website, and they were also provided as handouts for this presentation as well. So the first tool is the self-assessment guide. This is a tool completed by clients that assesses 5 different areas that are important to returning to work. The client rates their current abilities on a 10-point scale, and that's compared to expected job demands. So as you can see on one part of the screen here where it says physical activity, it shows their current ability scale compared to expected job demands. And at the end of each section, there's a summary page that is reviewed by the client and the clinician, where it goes through strengths and challenges for each section. And this is to help the clinician, also the client, determine the readiness to return to work for each section. The self-assessment guide is one of the tools I'm going to go through for the case study, so hopefully you'll see it in its full use and it will make more sense. The second resource is the Regional Resource Guide. This is a resource that provides an overview of different community resources that are available to support with return to work. So it contains information on resources for various employment services, organizations that offer skill building and education related to return to work. And then for each organization, it provides an overview of the service and also contact information for that service. And it's broken down into the 7 different subregions that comprise SWOSN. So just as an example here, one of the resources on the one side of the screen is for Grey Bruce, the other one for Chatham-Kent, just to give an example. There is a financial supports resource, and this provides information on job benefits available for people who have experienced a stroke. This includes information on programs such as Ontario Works, Ontario Disability Support Programs such as ODSP, Employment Insurance, and Canadian Pension Plan Disability. So for each benefit, it explains what the benefit is, what the eligibility criteria is, the application process, the duration that person can receive the benefit, and also the potential amount that they might receive. So this is a really good resource to provide clients and go through with them for those who are experiencing financial concern. The next resource is the Jobs Benefits Questions resource. So it outlines questions to ask your employer if you have experienced a stroke. Questions are related to short-term and long-term disability and also extended health benefits. And again, this is another great resource to provide and go through with clients that have financial or benefits questions. And then lastly, vocation doesn't always mean work, but it can also mean volunteering. So we developed a volunteering after stroke resource. It provides information on the benefits of volunteering, the process of initiating volunteering, and also where to find volunteer opportunities. So now I want to provide an opportunity to kind of go through an example of using one of the resources, so the self-assessment guide. So I'm going to do that through a case study. So for the case study, it's around a 60-year-old gentleman. He is 1 month post left MCA stroke. Post-stroke, he experiences right-sided weakness, fatigue, challenges with multitasking, and he also has word-finding difficulties. Previously, he worked at Home Depot. He worked in a storeroom, unloading shipments, stocking shelves. He typically worked 10:30 p.m. to 6:30 a.m. He lives in a small town. His driving license is not suspended, but he was advised not to drive by his physician, and he has a recent implementation of a pacemaker. So we're going to say that this client is coming to outpatient services. He identifies that return to work is important to him. So as part of my session with him, I complete the self-assessment guide. So this is the self-assessment guide. So I'm just going to go through it. So the first part of this resource just goes through what the guide is. Like I said, it goes through 5 different critical areas that are important for returning to work. So I'll show you each one. The first part, it just gives a detailed explanation for a client in terms of how to use it. Typically, when I'm using this tool with the client, I go through this with them in detail. Here we can see the current abilities scale, where they rate their current abilities from 0 to 10. 0 being they have limited abilities in this area, 10 being that they have really good abilities, and this is compared against the expected job demands. So again, 0 being this skill isn't important at all for me to do at my job, 10 being this is a very important skill for me to have to do at my job. So I go through the example with clients just so they have a good understanding of it. And then we get into actually completing the guide. So for the first part, this goes through physical activity. So the first piece of this is use of arms. So consider activities including reaching, lifting, grasping, coordination, fine motor skills, etc. And the client rates their current abilities. So for this case, this client rated his current abilities as around a 6. And this is quite a discrepancy between his expected job demands at Home Depot, where he needs to be up around a 10. And then it goes into repeated use of reaching, lifting, grasping, etc. Again, there's a bit of a discrepancy because he rates his current abilities at a 5. He needs to be at a 10 in order to return to work. The next part is use of legs. So consider activities including balance, coordination, strength, walking, squatting, kneeling, etc. Again, there's quite a discrepancy. He rates himself at a 4 currently, and he needs to be at a 10 for him to return to his job. We look at repeated ability to do things like bending, kneeling, walking, climbing. And again, quite a bit of a difference. He rates himself at a 3, needs to be at a 10 to return to work. And the last part of physical abilities is vision. So he says his vision is really good. It's a match for what his current abilities are compared to what he needs to do at work. So like I said, at the end of each section, there's a summary page. And this is where the client lists their strengths and their challenges. So the strengths in this section is he says, I can see well, no issues with my vision. Challenges, he needs to be able to do repetitive reaching, bending, lifting, standing, and he's still having right arm and leg weakness. And he's also tiring really easy as well. The clinical considerations piece, I just added this for the sake of the presentation to keep myself on track. Normally, this isn't in the self-assessment guide, but I just wanted to list some ideas that I would have if I was using this with this particular client. So as I'm an OT, from an OT perspective, because he's having right arm weakness, I'd want to assess and treat the upper extremity. If a physio was going through this or we reviewed the results with the physiotherapist, they might want to focus on building lower extremity or working on lower extremity weakness and working on strengthening. We need to consider his restrictions. So he has a recent pacemaker implementation. So in this case, we will want to talk to the physician on the team, seeing what are the current restrictions, what kind of activities can we engage in. As an OT and PT, we're probably going to work on building endurance and functional tasks. We may want to simulate work tasks in a treatment session. So for example, for stocking shelves, we might want to create a type of task where he has to do repetitive reaching and bending. We want to consider adaptation to work tasks. So is there certain things that he can sit and do rather than stand? And then also providing education on fatigue management strategies as well. So that's the physical activity section. And then it moves into communication. So the first piece is expression. So how well are you able to express your needs? He rates himself at a 6. He needs to be at an 8, so a little bit of a difference there. Writing, he says his writing is pretty good. He's not having difficulties. It's matching what he needs to do at work. How well can he follow conversations? He rates himself a 9. He needs to be at a 10, so not too bad. Reading, again, there's a little bit of a difference, but not too bad. And then listening, so joining in on conversations, listening and speaking, there's a little bit more of a discrepancy here. He rates himself at a 7, needs to be closer to a 9. And lastly, writing. So again, a little bit of a difference there, rates himself at an 8, needs to be at a 10. For the summary page for communication, he says he's able to write okay, but he sometimes has difficulty finding the right words. He has no difficulty with reading. Some of the challenges is he still has some difficulties with word finding, which makes it hard for him to have conversations with others. And with word finding difficulties, he sometimes gets nervous in social situations. So my clinical considerations for this would be, if I'm the OT doing it, I might want to refer to an SLP if that's not already initiated, to assist with things like word finding difficulties and following and participating in conversations. And as a team, looking at opportunities for him to practice with speaking with others. So maybe there's aphasia or conversation groups in order to get him more comfortable speaking with others, because this is something he needs to do in his job. The next piece is thinking skills. So it looks at memory. He says his memory is really good, so that's great. Concentration, he's having difficulty with concentration. There's quite a bit of discrepancy between what he can do now and what he needs to do for work. Problem solving, a little bit of a difference. Thinking speed, a big difference. And he's also experiencing mental fatigue. And then planning and organizing is also an area of challenge. So summary, his strengths. So he says his memory is good. Challenges, he has a lot of difficulty with attention and multitasking, and this is something he needs to do at his job. He's easily distracted, and he has difficulty with organization and problem solving. So clinical considerations. So if the OT and SLP were looking at this, we'd want to assess and treat cognitive difficulties or cognitive communication for SLP. We may want to stimulate tasks that he would need to complete at work. So maybe we set up a task where he's stocking shelves and recording inventory at the same time. And then also, like I said earlier, education on energy conservation strategies. The next area is emotions. So looking at frustration. So he is experiencing a bit of frustration intolerance. He's not coping with stress well, which he needs to do at his job. His interpersonal skills, there's a bit of discrepancy there. And he's not feeling very confident in his current abilities, and he needs to feel more confident in order to return to work. And then this little section of the self-assessment guide here, it just goes through some questions. Some of them kind of mirror the PHQ-9. So in this case, it's looking at depressed mood, which he's saying he's experiencing. He's having less interest in activities that he used to enjoy. He is feeling hopeless, poor concentration, and also having lack of motivation. So then we look at, for every box that he clicked yes, how much is this interfering with your activities of daily living, which he's saying quite a bit. He's rating himself at a 6. So his strengths for the emotions section, he says, I don't think I have any. Challenges, he's having a hard time dealing with stressful situations. He's sometimes feeling anxious when socializing with others, and he's currently stressed about his finances with not working. So referral to social work if not already initiated, or if the social worker is going through this with the client, they have some things to then work on. So things like developing coping skills, working through depression and social anxiety, maybe providing some deep breathing techniques or working on breaking down a problem into smaller steps. And also, whoever the team member is filling this out, because there is some financial concerns, it might be a really good idea to then bring out the financial and benefits resources that are part of the Return to Work Toolkit. And then the last piece of the self-assessment guide is driving and transportation, so driving ability. And if you remember in the case study, it said that his license isn't suspended, but he's currently advised not to drive by his physician. So in this case, his current abilities are 0 because he's told not to drive, and he needs to drive to get back to work. So his strengths, he says that I do have a family member, a family friend and his wife that are able to drive me if they need to. He lives in a small town. He has a 25-minute drive to work. Uber and taxi rides are expensive, and he doesn't want to burden his family. So clinical considerations, I do find transportation can be challenging sometimes, especially if someone doesn't have their license, it doesn't look like they will. I always try to consider alternative modes of transportation. So is there family members that can drive or friends, or is there a person who lives in your town that works with you that you can get a ride with, looking at bus routes and Uber, but it can be challenging. And then also from an OT perspective, I would want to talk to the physician to determine if I can support with return to driving screens. And then we have an additional consideration section. This is a newer section that we added to this resource. So overall readiness to return to work, which I think is really important. He rates himself at a 4, so he's not quite ready. We also added this piece where we look at accessibility. So is the work environment accessible? So all different aspects of the work environment, like washrooms, break areas, entrances, etc. Aids and devices, or any aids and devices that we can use to help this person do their job. And then also job adaptation. So can hours be modified? Can tasks be modified? And clinical considerations. So I would say don't just assume you know what the work environment looks like, always ask. So for example, I've been in a Home Depot many times. I can imagine what it looks like, but I might not understand all the nuances that exist within that work environment if I just assume. I need to consider what aids this person could use to return to work and what's realistic in the workspace. And then also for myself, for example, I don't work in a return to work specific clinic. I'm not responsible for writing return to work plans. It's something our physicians do. But I can start to talk about ideas for modifications or ideas of what a gradual return to work plan might look like. Okay, and then this is the last part of the resource. This is a summary page. I really like this page because it ties everything together. We write down all of the strengths, all of the challenges, and then from there, I find it's really nice because it helps to derive goals that we need to work on. So in this case, like improving strength, managing fatigue, improving ability to pay attention, working on word finding, being better able to manage stress and return to driving. So it's a really nice way to kind of condense everything and look at, okay, if you want to return to work, what are the things that we need to work on and what goals can we set? And then there's a place for additional notes as well. So again, this is just one of the tools that we go through. So the last part is just looking at practical considerations. So the first, excuse me, I'm just going to have a drink of water. So this tool is supposed to be meant as an interdisciplinary approach. So I'm an OT. I try my best not to just focus on an OT perspective because it's meant to be used by multiple different people on the team, whether that's an OT, a physiotherapist, speech language pathology, social work, physicians. It's really meant to be used by anyone. It can be used across multiple types of care settings with various disciplines. So like I said, I don't work in a return to work specific clinic. It's not just meant to be used there. It can be used across inpatient, outpatient, and community organizations. I do find it helps the team to engage in client-centered goal setting because we're really considering what's most important to the client and getting them back to something that's really important to them. I find the self-assessment tool especially, like I said, it helps to direct assessment and also intervention. And it can really narrow down what skills we need to work on in order for that person to return to work. We need to consider when we can use supportive conversation methods. So I have used this tool with people that have like a mild aphasia. Some of the resources can be wordy. So trying to figure out how to make that easier for someone using supportive conversation techniques such as writing keywords, or sometimes I use the FACES scale. The return to work toolkit doesn't have to be used in its entirety. It should be patient focused, so what the patient needs. So you may only use one or two parts of the resource within the toolkit, or you might use all of it. You just kind of have to meet with the client where they're at. And also the self-assessment guide, I find it can be quite a lot for some people. So it can be completed over multiple sessions rather than just having to do it all at once. It's also can be used where the client uses it by themselves, or we do it together in therapy. And I do believe there's a benefit to using and discussing return to work tools early on. I really find it helps give the patient context for therapies and also purpose behind what they're working on and what we're doing in therapy. So the benefits of the Return to Work Toolkit, it helps facilitate collaboration as a care team to form goals that's most relevant to the patient. It creates a standard practice amongst providers. So it's an education tool for providers as well as the patients. Like I said earlier, a systematic way to explore work environment from the patient's perspective. So again, so important to understand the patient's perspective of what the work environment is. And I really feel it helps to address barriers in advance and better appreciate nuances in work environments and what those barriers are going to be and trying to work through those barriers with them. So the last piece is just going through additional resources. So obviously the SLOSM Return to Work Toolkit is just one of many return to work tools that we can use with clients. There's also really great resources in Heart and Stroke, Toronto Stroke Networks, and also American Stroke Association. So really good areas to look for other return to work tools that you can use in your practice as well.
If people have questions, could you please type them in the chat and I will refer them to Nicole and we'll see if we can get through a few questions. On the screen is the QR code to do an evaluation of this session, so please take a moment to do that as well. So I have a few questions written down. I'll start with me
Yeah, sure.
so people have a moment to type into the chat.
Yeah, absolutely.
So I want to ask you how you manage advocacy to employers. Is that something that you have a specific way of doing? Do you do that only through an outpatient program? I'm just interested in the connection to the actual employers themselves and how that happens.
Yeah, so I mostly focus on return to work in outpatient clinic. I would say that that's one of the challenges, and I think a barrier for myself as well. I often don't contact the employers. I'm usually kind of the middle person. We're coming up with ideas for plans, return to work schedules, things like that. So unfortunately, I don't have a lot of experience actually reaching out and advocating within specific jobs and to employers, but I definitely think that that's a barrier and something that myself I'd like to explore more.
Mm-hmm. North Bay was asking, they're wondering if you ever asked the employer to look at the toolkit once it's completed.
No, I haven't.
Mm.
That's a really good idea, though, and I like that idea and something that I'll probably move forward. Because I think it would be really beneficial just because then I think the employer can then better see what the challenges are and then start to work with the patient to actually go through and make modifications if possible. So that's a very, very good idea.
Mm-hmm. Great. Um, just in terms of return to work, who would work on it at your hospital? Is it across the continuum or does it mostly happen in outpatients? I know it's an interdisciplinary team approach, but where exactly in the continuum of care can you kind of start and go kind of full force and return to work?
Yeah, I would say because I work on inpatient and outpatient, I would say for inpatient, I find it's a little bit too early to really start working through goals related to return to work. It's a conversation that we have, but it's usually a longer term goal, and we're more focused on getting the person home safely. So I would say for myself, when I'm addressing return to work, it's in the outpatient program that I work in because that's where I feel like people are starting to think about return to work a little bit more now that they're home. And it becomes a bigger focus of their rehabilitation. So I would say that that's where I use it the most, just because in inpatient, we're not ready for that yet.
Right. Okay. We have another question from North Bay, and it was something that I had kind of written down too. Do you have any good suggestions for patients with poor insight into their abilities when you were reviewing the rating and they rated
Yeah.
themselves here and the job was here? Do you ever find that their rating is not quite accurate?
Absolutely. And I think that that's one of the biggest challenges with using the tool. So a couple different ideas that I've had. Sometimes it works, sometimes it doesn't. Sometimes if I feel like I've developed a good enough rapport with that person, I'll maybe mention, in therapy, you say your attention's really good, but in therapy, here's some examples of maybe where it wasn't as strong and we've been working towards that. But sometimes it doesn't work and people aren't receptive to that. So sometimes also, if I can, setting up tasks that would simulate work as best that I can, and almost like getting them to do it and see for themselves that they're having challenges. And then if that works and they're starting to say, oh, this is a lot more challenging than I thought it would be, then we can go back to sitting down and going through that section and saying, okay, now that you did that task, what would you rate yourself at this point? But I would say sometimes even with that, it can be challenging because even if people are doing poorly and they don't have the insight, it's really, really hard to bring that out for some clients.
Right. Okay. Next, is a couple two questions. Are small private employers legally bound to accommodate people with disability? Are you
Oh,
aware?
that's a good question. I don't know if I honestly don't know that for sure. I my experience is I think there is legal documentation around that. Um, but from my experience, it doesn't always happen. I don't know if an employer is not willing to accommodate, if that can then get carried in a legal case or what that would look like. But even if they are legally bound, I still find there is a lot of barriers in terms of if the modification is available and if the adaptation is available. But I don't know the legal nuances around that.
Okay. And the other question was what kind of accommodation the employers can provide to their employee? Can you give some examples of the types of accommodations you've seen?
Yeah, so sometimes with my clients, so a few different examples, doing so modified hours to start, usually a gradual return to work plan, starting at say like 4 hours every other day, and then we build up. In terms of modifications, it can be things like having regular breaks. I've had some people that have really intense noise sensitivity or they get stressed really easily. So having access to a quiet room where they can settle them down can be really helpful. I've had, in terms of adaptive aids, I had someone with MS. Sorry, I know not stroke related, but was having a lot of difficulty with arm function, which was really important for his job. So we're working on like modifications for built up grips and different adaptations that or tools that we can use to like he worked on a production line. So like being able to scoop off of the production line rather than having to use fine motor. So there's lots of different things that you can do. I would say the biggest thing too is fatigue management. So making sure that people have that gradual return, they have lots of opportunities for breaks, and often having access to a quiet space, which can be challenging in some work environments.
Yeah, great. Thank you.
Mhm.
We have a question. Do organizations such as March of Dimes offer assistance or advocacy for return to work? And are there any other organizations that might be helpful or even ministry programs, government programs?
Yeah, I think it depends for March of Dimes. It might depend on the different area. I don't think within our London region there's something related to return to work. It's something I can look into and get back to you though. And other than that, a lot of the organizations in our area, and it is outlined in one of that resource that was provided. It goes through a lot of organizations that provide support with return to work. A lot of ours are like employment services, so like leads or things like that. So it's not necessarily stroke specific, but there are different organizations that work with individuals that have disabilities and getting them back to work. But I
And
think it would largely depend on where you are and what organizations are available to you.
what's the resource you're speaking of that people could open? Is it?
It is the which one is it? I think it's called General. Let me just pull up my PowerPoint. I think it's a General Resources one. The Regional Resource Guide.
Don't have it.
Oh no? Okay, I can resend that.
Yeah, if you just email it now, then Terry can post it in the chat for people. Thank you.
Okay, perfect. I will email that right now.
Okay. I'm just a comment. March of Dimes Stroke Navigator here. You can look into employment services through our organization. So this is the navigator, and Sault Ste. Marie actually works through the
Okay.
March of Dimes. So
Oh, amazing.
they can assist with return to work. So March of Dimes Stroke Navigation is in Timmins and Sault Ste. Marie. Those are two organizations house our post-stroke transitional care program.
Okay.
So thank you for that. Another comment from one of our navigators: can obtain physical and cognitive demands through national occupational codes on Canada government websites that could assist with answering self-assessment questionnaire. And Shadette, you're telling me it's the return to work resources sheet. It was sent out. So
Okay. I can resend it again though, Sue. I'm just sending it right now.
complete. Okay, I just didn't see the title that you said. Yeah, so do you want to post that again, Terry, in the chat, the
Okay, perfect.
complete return to work resource guide, and then people can see it again. Thank you, Jeanette. Another question I had was, do you ever help people switch their job to virtual? You know, with the pandemic and the way the workforce has changed, does that ever come up that they could return to work, but you set them up in a virtual position rather than going into their job?
Yeah, I haven't done that. However, I can see where it would be well suited. And I guess largely it would depend on the job if that's a possibility, because I have talked about it with clients sometimes. And I have had one person actually who did switch or did part-time, like a hybrid, so virtual and in person, because in person was too much. But it largely depends on if that a possibility within the workplace and if that's something that can be modified, because some places it's just not a possibility, but if it is, it's a really good option for some people.
Right. Excellent. Okay, so I think we'll wrap up. Nicole, thank you so much for spending your time with us today and taking you away from your patient care. Return to work is a very popular topic, and to expand the things that we have access to in order to help us with our patients and getting back to work has been very helpful. So thank you again. We really appreciate that you were here today.
Okay, thank you so much for having me.